Hello again, everybody. We are going to talk here about polymyalgia rheumatica, and this is fairly common in the community, so it's something you can expect to run into on your exam. Now, polymyalgia rheumatica looks a lot like some of the other disorders we've talked about in our rheumatology videos, and it also shares, it also can herald, I should say, a very, very, very emergent disorder. And we will go into that, and hopefully by the end of this video, you'll have an understanding of how to work this up, how to distinguish this from other disorders, and what to look out for in these patients going forward. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button in the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already donated. Definitely subscribe to my channel and you will get notifications every time I put a new video up, which I try to do a few times a week. Okay, so polymyalgia rheumatica is an inflammatory pain disorder, and it's associated primarily with the proximal muscles. So because there's pain with these proximal muscles, so think the thigh and the arms and the shoulders, they're going to have a hard time with things like getting up from a seated position, going up the stairs, combing their hair. Oh boy, what does this sound like? Sounds like polymyositis. And they are very, very similar. The difference is polymyositis is genuine weakness. Even if they, try to muscle through their pain, they're not going to be able to do it. Whereas polymyalgia rheumatica, it is a pain syndrome. So they're not necessarily weak. They just don't want to move because it hurts. So that's a key distinction. However, on labs, we can distinguish the two, and we'll go into that. You probably already have an idea if you've watched my polymyositis video. Okay, so what we look for is a symmetrical pain and stiffness of the shoulder and upper arms, can extend to the proximal lower extremities, but it is a kind of more of an extremity thing. You can have constitutional features, so be careful about that. If you've got a patient who's got unexplained fever, night sweats, unexplained unintentional weight loss, you need to consider working them up for a malignancy. So we think of the possibility, maybe a lung cancer if they're a smoker, or maybe breast cancer. Maybe they need to get their colonoscopy. Maybe we need to do an SPEP for multiple myeloma. You got to start thinking about those things. The lifetime prevalence it's pretty prevalent. 2.4% in women, almost 2% in men. So it presents in both genders, about 1 in 50. So it's not uncommon. There is a correlation between PMR and temporal or giant cell arteritis, and we're going to get into this in a few slides. So look for an older adult coming in complaining of generalized aches and stiffness. Okay, that is not specific at all. However, what you should know is that this is that typical presentation of difficulty going up the stairs, difficulty getting up from a seated position. Whereas if you ask them, are you able to do things with your hands? Are you able to type? Are you able to text? Are you able to sew or knit or anything like that, where it's distal muscles that shouldn't be affected? They'll say, yeah, I can do that. Okay, so now you know it's muscle pain limited to a specific area. That will help you. It does tend to be worse in the morning, like a lot of inflammatory things, so keep an eye out for that as well. So they will have normal strength. However, when you try to have them, clench your hands or something like that, it will hurt. I shouldn't say clenching your hands. Have them push against your hands, right? So you put your hands up and they put their hands up. You have them push, okay? That will elicit pain. This is a clinical diagnosis. However, there are a number of labs that we do have to do to distinguish this from other things that can cause weakness. Things like anemia, hypothyroidism, polymyositis, even malignancy. Okay, so this is the classification criteria if you want to look at this. This is where it hurts. So what do we do for our workup? Well, we're going to get a SED rate, we're going to get a CRP. These are looking for inflammation. We would expect these to be positive, certainly in an inflammatory pain disorder like polymyalgia rheumatica. Creatine kinase, aldolase, and LFTs. These look for muscle breakdown. So muscle breakdown. This, if it's positive, would suggest polymyositis or dermatomyositis. TSH would look for hypothyroidism. Rheumatoid factor is good to get in anyone who's coming in with new unexplained musculoskeletal pain, even though in these patients it would be highly unlikely to be developing RA for the first time. And then SPEP you may get if the constitutional features are really salient. And what we would expect to see are just markers of inflammation being elevated. Everything else is negative. So these are pertinent negatives. Creatine kinase is within normal limits. That pretty much excludes the myositis. TSH will be normal, excluding hypothyroidism. Rheumatoid factor will be negative, and SPEP should be normal. So the cornerstone of management in polymyalgia rheumatica is prednisone. So we do not give NSAIDs for polymyalgia rheumatica, and this kind of surprises some people because it's an inflammatory pain disorder, but NSAIDs do not really help too much. So we give prednisone. Prednisone is the cornerstone of management in PMR. And this should say PMR here. So patients with PMR do have a really good response to corticosteroids, and then we can taper them down to the lowest effective dose. However, most of these patients are going to need to be on steroids at least for an extended period of time. So for that reason, anytime you have someone who's going to be on steroids of any dose for 3 months or more, you need to protect their bones. So what I would do is I would get a DEXA scan before you start the steroids. And then, if you know they're going to be on steroids for an extended period of time, or you can start after 3 months, you want to put them on a bisphosphonate and then supplemental vitamin D and calcium. Okay, so calcium carbonate, ergocalciferol, and a bisphosphonate, like alendronate, for instance. Now, after the diagnosis and you've started treating them, you need to screen them for temporal arteritis. All right, so temporal arteritis is usually a more acute presentation, but they're coming in for the first time, so you want to make sure that they don't have any signs of temporal arteritis. So scalp tenderness, a hard artery in their temporal area, visual changes, any kind of decrease in visual acuity and stuff like that, headaches. You want to screen them for that, because if they do have symptoms of temporal arteritis, your next step is to get a temporal artery biopsy. And then you also want to set them up with an ophthalmologist. But the treatment will be the same. It's still steroids. You may need to do a higher dose of steroids, but it's still, the treatment is steroids. And on step 3, you do not need to know dosing. You do need to know route, but you don't need to know dosing. All right. So the management would look something like this. Prednisone, PO. If they're going to be on steroids for an extended period of time, you can do a DEXA and then put them on a bisphosphonate, vitamin D, and calcium. You want to advise them of side effects of the medication. Anytime they're on a serious medication like corticosteroids, you want to advise of side effects. I would say the same thing if it was, infliximab or something like that. If you're just giving them NSAIDs, you might not need to include that, but on CCS, it's always good to put on there. You'll send them off to rheumatology for long-term management, and then ophthalmology if there's changes in their vision. There are newer agents that are used for PMR, but you don't need to know those. This is kind of what we talked about with giant cell or temporal arteritis. These are some of the things you'll want to look out for. It is common in people with PMR. About 10 to 20% of them go on to develop giant cell or temporal arteritis. So like I said, when you suspect it, get a temporal artery biopsy. However, when you are putting your orders in, let's say on CCS, if you get a case like this, you're going to order temporal artery biopsy and prednisone, which you may do IV. You may do methylprednisolone, high-dose corticosteroids. So you need to do both at the same time, because we don't wait for the biopsy to come back. The biopsy will confirm it, but we don't wait for the biopsy to come back to start treatment. Start treatment immediately upon suspicion. Okay? Now, this is a table that will help you distinguish PMR from fibromyalgia and chronic fatigue syndrome. So fibromyalgia and chronic fatigue syndrome share a lot of overlaps, and PMR shares some overlap because it causes weakness, but it's more due to pain. So you can kind of see the overlap between these. So I wanted to put this out there for you. The big thing with PMR is it's inflammatory. Fibromyalgia, chronic fatigue syndrome are not inflammatory by any means. So that will help you right there. Fibromyalgia has those trigger points that will help you, and then with chronic fatigue syndrome, it's mostly just sleep. They don't have difficulty with pain at all. All right. So remember, though, if you've got a patient with fatigue and weakness, make sure you get your CBC, looking for anemia, TSH, looking for hypothyroidism, creatine kinase, looking for polymyositis, and a SED rate, looking for PMR. So those should all be part of your orders. All right, so to recap, PMR is an inflammatory pain disorder associated primarily with the proximal muscles. So very similar in distribution to polymyositis, but PMR is more of a pain thing, whereas polymyositis is more of a weakness thing, but there is overlap. It affects older adults, so look for a 65-year-old coming in with, sudden onset of pain and weakness, maybe constitutional features. The best initial diagnostic test when suspecting PMR is a SED rate. However, that's kind of working backwards. Remember that we work up based on presentation and not just jump to a most likely diagnosis and just test for that, right? So the best treatment for PMR is corticosteroids. NSAID's not typically used. Keep an eye out for the possibility or the development of giant cell arteritis, which is a huge complication of PMR. If they do have symptoms of temporal arteritis, get a temporal artery biopsy and high-dose steroids at the same time.